Hi, so I will be covering a very important topic which is liver cirrhosis in this video. Mind you, we will be very brief and I will do a very quick run through it. And I'm going to try to make it simple and in point wise so that you can make notes if you want to. Okay, let's go. Putting liver cirrhosis in these headings: definition, etiology, clinical features, complications, and diagnosis, especially from pathological point of view, the morphology. All right, brace yourselves. We'll be very quick with it. Okay. So cirrhosis is the morphological change associated with chronic liver diseases. Whatever be the cause of chronic liver diseases, it will be leading to cirrhosis. We'll be discussing it further. So it refers to the diffuse transformation of the liver into regenerative parenchymal nodules, which are surrounded by fibrous bands. So you have to remember two things: fibrous bands and nodules. Remember these two words, okay? So this is the normal smooth liver, right? And now this liver has nodules, and these nodules are separated by the fibrous bands. It's an end-stage irreversible liver disease. So many of the liver diseases are leading to this. The liver tissue is replaced by fibrosis and nodules. We'll see the morphology later. Smooth liver surface now has nodules. In advanced cirrhosis, liver becomes shrunken. So again, the leading causes, first of all, is the chronic hepatitis B, chronic hepatitis C. So the infectious causes. Then we also have another most common cause, which is the alcoholic liver disease. And then another one, which is a rising cause, you could say, is in the recent years, is non-alcoholic fatty liver disease, more common in women. Now coming to clinical features. So there are a lot of clinical features. We'll be going very quickly. Okay, anorexia, patient will have weight loss, patient will have classically patient will have jaundice. Of course, it's liver disease. So patient will have jaundice. Why? Because the bilirubin metabolism liver is very important. I hope you remember that UDP transferase enzymes. But it occurs in late course of cirrhosis. So you can see this patient who has jaundice. He's become young. So they are elevated estrogen levels. So normally estrogen is removed by the liver, but in cirrhosis this is not removed. So this is, you can see, this is not normal breast in a male. So this is gynecomastia. This is called as gynecomastia when there is breast enlargement in male. There is something called as testicular atrophy and not spindle, spider angiometry. So in this picture you can see this spider-like web, like these are dilated blood vessels and coiled blood vessels. And there is something called as palmar erythema. So the palms are naturally more red. All of these. So elevated estrogen level is causing these two things, but there are other two features: spider angiometry and palmar erythema. So very important symptoms is ascites, which is ascites is abdominal distension, right? So basically, what is happening is fluid is accumulating in the peritoneal cavity, mainly because of portal hypertension, but also because of low albumin, and that is contributing to low body pressure that causes edema in general. So this is ascites, very important. Normally, what is the venous drainage of liver? We have portal vein, which is draining to the liver, and then the venous blood goes to hepatic vein. Now, what if the liver is done for? Because of the nodules and the fibrous bands, blood is not going to flow through the liver. All of the blood backs up into the portal vein, it becomes engorged, and that is why it has hypertension. Another thing is, we know that liver synthesizes albumin. Protein is most commonly albumin. And if there's no albumin, oncotic pressure will be low, which contributes to ascites and something called as pitting edema. So when you go in fourth year, they'll ask you the differential of pitting edema. So one of them will be ascites, just liver disease in general. Another thing is coagulopathy, because clotting factors are also synthesized in the liver. So if there are no clotting factors, that will be leading to elevated PT-PTT, thrombotic. So there's something called as mean arterial pressure, which is different from blood pressure. So that is decreased because of that causes low systemic vascular resistance, and eventually hypertension may resolve, or it may lead to hepatorenal syndrome as well, which is a complication. Cirrhosis, we'll discuss this later. Now, what is happening because of portal hypertension? The portal vein has something called as collectors, which are connections between portal vein and some systemic veins. These are called as photovenous systemic shunts. Normally, these veins are small and connect, but during portal hypertension, these open up, and portal vein is sending all of its blood into these vessels, and they become engorged, dilated, and profuse. And more, why are they problematic? We can blame. Most prominent one is this at the esophagus or stomach, so that will cause upper GI bleeding, or as we call it, hematemesis. Then we have at the rectum, which is internal, which will cause internal hemorrhoid, and then we also have at the umbilical level, so that is called as epitomatosis. Specifically, its name is caput-medusa. So this is the esophageal varices which is bleeding, and then again caput-medusa, total venous filling, all of its blood here. Coming to complications, three complications that you have to remember: hepatorenal syndrome, and hepatic encephalopathy, and spontaneous bacterial peritonitis. Again, there is so much detail on this: MELD score, Child-Pugh score, SAG, and there's so many scoring and the things that you have to do, that you have to remember for clinical purpose. But for pathology, very brief introduction to cases. Hepatorenal syndromes, so this patient presents with pre-renal feature, so patient will have low sodium levels, but urine examination is normal. There are no proteins or RBCs etc. seen, but it is difficult to treat than a normal pre-renal failure. Hepatic encephalopathy. This is happening because urea cycle happens in liver, so liver is diseased. Loss of urea cycle, that contributes to increased level of ammonia. If you remember urea cycle, the purpose of it was to use ammonia. Now, how is it? So this ammonia goes to brain. The excessive ammonia goes to brain. What happens? Mainly confusion. And very classic symptoms that you have to remember is hysterexis. The patient अपना हाथ ऐसे सीधा नहीं रख पाता, ऐसे flapping tremors आते रहते हैं. So that is called as hysterexis. It is a clinical diagnosis. Lastly, another complication, spontaneous bacterial peritonitis. By the time you have this, that is a ascitic fluid infection, then hepatic incef might already be there in the patient. So it is infection of the ascitic fluid, bacteria entering from gut, mainly E. coli. Patient will present with fever and abdominal pain along with incef. Paracentesis, it is the procedure by which you take out the ascitic fluid from the peritoneal cavity and you send it for examination, either for counts. So if the neutrophil count is more, so cell cytology, you do it in the lab. So more than 250 cells per mm cube, that contributes to it. That means diagnosis of SPP is confirmed. Or there's something called as SAG. So you will read about this, and of course confirming the organism system. Diagnosis of cirrhosis is often based on clinical findings. You already have a liver disease which is causing cirrhosis. You already have these symptom patients, and then you do ultrasound, which will tell you early में तो nodularity and irregular areas होंगे, but advanced में it will become shrunken. It's neither specific nor sensitive. But definitive diagnosis, of course, liver biopsy. But that is rarely done because clinical diagnosis is valid enough. Now, this is important from pathological point of view. Grossly, parenchymal nodules. You have to remember two words: parenchymal nodules and dense bands of fibrosis. If you remember that, that is enough. And you can also write that the smooth liver capsule converts into a bumpy surface. Now, on microscopy, how do you see? This is seen by collagen stains, the special stains for collagen. Mason trichome is one of them. This is the this picture is showing Mason trichome. So the size of the nodules, the pattern of the scarring, the degree of the parenchymal collapse, the extent of thrombosis, all vary, and to some degree between individuals on the same disease. Eventually, the morphology will regress, where patient will have just, the liver will just have incomplete scars. So this is an alcoholic cirrhosis in an active drinker after long-term abstinence. So do you see these nodules? This is not normal liver, and these are fibrous bands in between. So these are again thick bands of collagen, separate rounded cirrhotic nodules, and after 1 year of absence, most of the scars, these scars are gone. You can appreciate the scars have thinned out, right? There's something called as decompensated cirrhosis, which is basically when the cirrhosis is complications, any of the complications that we discussed. That was